Hi, my name is Johan Perry. I would like to welcome all the lecturers, Batch 25, and the viewers to the Group 5 presentation. I'll be presenting on one of the deadliest organisms, which is Middle East respiratory illness, or commonly known as Mers-Cov. Mers-Cov is a viral respiratory illness that is caused by coronavirus, first identified in humans in Saudi Arabia in 2012. Middle East Respiratory Syndrome coronavirus is considered to be responsible for a new viral epidemic. Epidemiologically, analysis was performed on data derived from all MERS-CoV cases who recorded in the disease outbreak news on WHO website. Demographic and clinical information as well as potential contacts and probable risk factors for mortality were extracted based on laboratory confirmed MERS-CoV cases. A total of 229 MERS-CoV cases, including 70 deaths, were recorded in the disease outbreak news on World Health Organization website over the study period. The case fatality rate in both gender was 30.5%. Disease occurrence was higher among men than women. Variables such as comorbidities and exposure to MERS-CoV cases were significantly associated with mortality in people affected with MERS-CoV infection, and adjusted odds ratio estimated were 2.2 and 2.3 respectively. Next, we'll move on to the morphology of MERS-CoV. Well, it belongs to the family of uh, Coronaviridae, and the genus is the beta coronavirus. The capsid is helical and enveloped. The genomes are ssRNA. Please to remember that they are the main causative agent of Middle East Respiratory Syndrome, MERS, and Severe Acute Respiratory Syndrome, SARS. Here you can see that they have the four main distinct structure on the virus. First will be the nucleocapsid protein. It is bound to RNA genome to make up nucleocapsid. Next is the spike protein, which is very prominent, critical for binding of host cell receptors to facilitate entry of host cell, followed by envelope protein, which interacts with the membrane protein to form a viral envelope. Lastly is the membrane protein itself, which is the central organizer of COVID assembly and determines the shape of viral envelope. In this image, you get to see that the spike glycoprotein followed by the membrane protein and also the gamma-glutamine esterase, which helps the virus in the attachment and destruction of certain sialic acid receptors that are found in the host cell surface, and also followed by the nucleoprotein and the genomic RNA. Now, I will pass to my friend on talking on behalf of the transmission.
Hello, my name is Jonathan. So today I'll be talking about the transmission of Mers-Cov. MERS-infected bats transmit the virus through their excreta and saliva. And then the transmission of the virus from camel to human happens through consumption of its milk and meat. Human to human transmission of the virus then occurs. And finally, transmission of the virus from a smaller group to a larger population occurs. Next, we would be seeing the symptoms possessed by the infected human, which is fever, joint pain, common cold, chills, headache, shortness of breath. Now, moving on to the transmission from animals to humans. It is not yet fully understood how people became infected with Mers-Cov, which is a zoonotic virus. It is believed that humans can be infected through direct or indirect contact with infected dromedary camels in the Middle East. The most critical question remains to be answered, that is, the type of human exposure that results in infection. Strains of Mers-Cov have been identified in camels in several countries, including Egypt, Oman, Qatar, and Saudi Arabia. Most Human cases do not have a history of direct contact with animals. If camels or other animals are the source, the route of transmission to humans may be indirect. Next, we will be going through the transmission from humans to humans. The virus does not appear to pass easily from person to person unless there is a close contact, such as providing clinical care to an infected patient. Undetermined droplet and direct contact, probably large droplet transmission, is suspected as the most likely route. This has been seen among family members, patients, and healthcare workers. Majority cases have resulted from human-to-human transmission in healthcare settings. All reported cases have been linked to countries in and near the Arabian Peninsula. Next, we will be looking at direct transmission and indirect transmission. Indirect transmission. This occurs through droplets expelled during coughing or sneezing, direct contact with patient or animals, ingestion of contaminated meat and animal products. In indirect transmission, touching devices or surfaces contaminated with virus and then touching the mouth or nose. Moving on, we will be looking at the clinical features. Okay. As for the incubation period, it starts anywhere between 5 to 14 days. The duration of hospitalization to discharge is 7 days and to die is 9 days, with a median of 4 days. Clinical range from asymptomatic to very severe pneumonia. 1/3 of the patients also have gastrointestinal symptoms. And in below we can see all the percentages attributed to the symptoms. Okay. Next, also in the clinical features, all the laboratory confirmed cases had the respiratory disease as part of the illness, and most also had severe acute respiratory disease requiring hospitalization. Common symptoms are acute, serious respiratory illness with fever, cough, shortness of breath, and breathing difficulties. Pneumonia has been the most common clinical presentation. In people with immune deficiencies, the disease may have an atypical presentation, such as diarrhea, which may be present atypically and initially without respiratory symptoms. Looking at the complications in fatal cases, acute respiratory distress syndrome, acute renal failure requiring hemodialysis, and also disseminated intravascular coagulation, pericarditis, heart failure, and also multiple organ failure. Now I will pass it on to Jaga, who will be talking about the lab diagnosis of Mers-Cov.
Hi, my name is Jega and I'll be presenting about lab diagnosis for Mers-Cov. There are two types of tests done to diagnose Mers-Cov, which are the molecular test and serology test. Molecular tests are used to diagnose active infection in people who are thought to be infected with Mers-Cov, based on their clinical symptoms and having links to places where MERS has been reported. Real-time reverse transcription polymerase chain reaction assays are molecular tests that can be done to detect viral RNA in clinical samples. The success of PCR testing depends on several factors, including the experience and expertise of laboratory personnel, laboratory environment, and the type and condition of specimens being tested. For laboratory confirmation of MERS-CoV infection requires either a positive PCR result for at least 2 specific genomic targets or a single positive target with sequencing of a second target. A person is considered under investigation to be negative for active MERS-CoV infection following 1 negative PCR test on the recommended specimens. Since a single negative result does not completely rule out Mers-Cov infection, in some circumstances, additional specimens may be tested. A known MERS patient is considered to be negative for active Mers-Cov infection following 2 consecutive negative PCR tests on all specimens. It is recommended to collect multiple specimens. Specimens can be collected including from the lower respiratory samples, which are the bronchoalveolar lavage, sputum and tracheal aspirates, and also from the upper respiratory samples, from nasopharyngeal and oropharyngeal swabs, from serum and also stool specimens. Serology testing is used to detect previous infection in people who may have been exposed to the virus. It has a two-phase approach, using 2 screening tests and 1 confirmatory test to detect antibodies to Mers-Cov. ELISA or enzyme-linked immunosorbent assay is a screening test used to detect the presence and concentration of specific antibodies that bind to a viral protein. Tests by ELISAs for antibodies against 2 different Mers-Cov proteins, the nucleocapsid and spike. If a clinical sample is determined to be antibody positive by the ELISA, it is then used microneutralization test to confirm the positive result. The microneutralization assay is a highly specific confirmatory test used to measure neutralizing antibodies or antibodies that can neutralize virus. However, compared with the ELISA, the microneutralization assay is labor-intensive and time-consuming, which requires at least 5 days before results are available. The specimen used in serology test is blood samples. If a clinical sample is positive by either ELISA and positive by microneutralization, the specimen is determined to be confirmed positive. If a clinical sample is positive by both ELISAs and negative by microneutralization, the sample is determined to be indeterminate. If a clinical sample is positive by only 1 ELISA and negative by microneutralization, the sample is determined to be negative. If a clinical sample is negative by both ELISAs, the sample is determined negative. Next will be the treatment and preventions for MERS-CoV. No vaccine or specific treatment is currently available. Treatment is sportive and based on the patient's clinical condition. An infected individual has to seek medical care, and treatment can be taken to relieve the symptoms of the infections. In severe cases, current treatment involves the support of vital organs functions. There's no vaccine for this infection. Therefore, precautions has to be taken by themselves. One must learn and practice washing their hands often with soap, if possible, to avoid virus and bacteria from being transmitted into their body. One must avoid touching their faces and even others, especially with unwashed hands, to make sure viruses don't affect them. Often touched surfaces must be cleaned and wiped with antibacterial solution. Last but not least, we should cover our nose and mouth when we cough or sneeze. Thank you for watching.